Hi, everyone. I'm Jill Feldman, a lung cancer patient and advocate and a co-founder of the EGFR Resistors Patient Group. My disclosures: I have lung cancer and I am a person of privilege. When we talk about health equity in cancer care, it's important to note that while there are global disparities, the definition of disparities are local and unique to the country, state, city, and community. Hearing the words "you have cancer" is one of those things you can't understand unless you've experienced it. But I want you to think about your life. Now, imagine you are going about your everyday life and suddenly you are drop kicked into a foreign country. You don't speak the language, the culture is unfamiliar, you don't know what's expected of you, you aren't familiar with the terrain, and you don't have a map. Yet, you need to figure out how to survive. Now, imagine how different the outcomes would be for those who have a navigator and can easily access resources compared to those who have to navigate the foreign territory without any help. Cancer is a disease that can affect anyone, but not everyone has a navigator or can easily access resources. Since 2015, the FDA has approved more than 25 new treatment approaches for lung cancer, including combination therapies and expanded approvals. I got involved in advocacy in 2001 after losing my parents and other loved ones to lung cancer. At the time, lung cancer was considered the invisible disease with little awareness and negligible funding for research. When I was diagnosed with lung cancer in 2009, research was finally moving in the right direction, and it continues to rapidly progress with new discoveries and more and better treatment options. Over the past 20 years, I have witnessed and celebrated the creation of a lung cancer community, and I have personally benefited from many of the advancements in research. I am grateful that my path was different than my parents', and I am hopeful for the future. But it's disturbing and just plain wrong that my good fortune is mainly a result of luck. Simply stated, I was lucky to be born into a white, middle-class family in the United States. Even more upsetting is that I represent only about 20% of people with lung cancer, the 20% who benefit from these treatment approaches. Despite all the advancements in all cancers, there are still vast disparities both in the United States and worldwide. They are rooted in a history of discrimination and systemic exclusion that has prevented specific communities from accessing and receiving the care they need. If we use the iceberg graphic as an analogy to depict the many layers of the patient community, you can see the engaged, educated, and empowered patients are only the tip of the iceberg. These are the patients who are likely to have access to and receive best treatments, participate in online communities, and join clinical trials. The majority of patients are below the waterline and deal with much difficulty in being seen and included, with a decreasing level of inclusivity that accompanies the patient populations that are submerged deeper in the ocean. And we must recognize that each layer of the iceberg does not, in fact, represent a singular construct of disparity. We have to use the lens of intersectionality to understand how each of the layers intersect and interact with each other to create an incredibly complex environment that creates and perpetuates health disparities. For example, on this slide, we look at recent lung cancer statistics in the US, and you see that combining poverty data with race and ethnicity highlights the intersectionality of these two constructs to identify our most vulnerable patients with lung cancer. Health insurance coverage in the US is one of the largest barriers to healthcare access, and having health insurance is strongly correlated with better patient health outcomes. Compared to privately insured patients in the US, you can see on this slide that those on Medicaid or other public insurance are significantly less likely to receive any systemic treatments, at 22% less likely. Specifically, 43% are less likely to receive certain combination treatments, and 30% are less likely to receive TKIs. Another area of disparities that is often ignored is supportive care. Prior studies suggest that communication with minority patients about prognosis, treatment options, and advanced care planning is suboptimal, which is a major barrier to the use of supportive care. The assessment and treatment of pain management is disproportionate among racial and ethnic minority groups, including access to pain medication and sometimes even the use of wrong medications for those in neighborhoods that are less likely to have adequate supply. There is an immediate need for interventions that address the disparities, which are complex and reflect social and economic inequities more than just biological differences. Looking at the iceberg graphic, there is a wide range of research documenting health disparities across numerous disparate, vulnerable, and underserved populations. However, understanding why these disparities persist, and more importantly, how they can be fixed to equalize and improve patient care in the real world setting, has not been well documented, especially given that these disparities are pronounced at several levels. As our communities become more diverse, it is increasingly important to recognize and address health disparities in all underserved communities. But we have to take a closer look at the system. On this slide, think about the tree as proxy for the system. It is bent to benefit only some populations. It's important to know that equality and equity are not interchangeable. They may sound the same, but implementation of one versus the other can lead to dramatically different outcomes for minorities. Equality means each person has the same resources or opportunities. In this case, the same size ladder. But even with equal support, reaching the fruit remains unequal. Equity means each person receives resources and opportunities based on their individual need. In this case, the exact size ladder needed to reach the fruit, an equal outcome. But from an actual justice standpoint, you have to look at the tree and first, acknowledge it is bent. Second, ask the vital question of why it is bent. And third, start the conversation on how to unbend it. Just fixing it isn't the correct answer. Thankfully, social justice is deservedly a hot topic, and we will no doubt continue to dominate strategic thinking in 2021. There are major efforts addressing diversity, inclusion, and equity on the federal level and from many leading institutions, but on their own, they won't eliminate disparities. While the major efforts are critical, many are failing to address the underlying persistent social injustices and determinants of health, including family, structural, financial, social, cultural, etc. Having access to quality care, clinical trials, or biomarker testing means nothing if people don't understand their options or if they don't have the proper support and resources, such as insurance, transportation, time off work, or childcare. There have been successful efforts to address support. The Greensboro Health Disparities Collaborative partnered with 2 cancer centers to test whether customized supports can improve the experiences of Blacks undergoing treatment for early-stage breast and lung cancer. Specially trained nurse navigators worked with patients to ensure they understood their treatment options and had financial and social supports. Before this study, Blacks were less likely to complete treatment than whites. But after the study, treatment completion rates increased among all patients, but they increased more in the intervention group and more Blacks than whites completed treatment. Personalized supports provided equity. But ultimately, no single injustice can be addressed in isolation or in silos. And many health inequities persist even after controlling for socioeconomic factors. For example, There can be two people with the same insurance going to the same facility, seeing the same doctor for the same condition, and still have different outcomes. Implicit biases are real. We all have them, but that doesn't make us a bad person. There's a lot we don't have control over, but we can address our implicit biases. What we can't do is ignore them. Regardless of what industry or sector we are in, and regardless of whether our individual jobs or whether we are in a position of power, we are all part of the health equity ecosystem, and we can all provoke change and make a difference. I like to think of it like the butterfly effect. A localized change in a complex system can have large effects everywhere. But change doesn't come from a place of comfort. People are very comfortable talking about disparities caused by external factors such as governmental policies and historical injustices, but much less comfortable discussing race and discrimination that are personal and that come within. Real change starts with self-awareness. It requires every one of us to take an honest look at ourselves, and then we can start to have bigger conversations. I was at an advocacy summit last January, and one of the sessions was on disparities in cancer care. During the Q&A, I asked the presenters what the best way would be to reach underserved communities like theirs to ensure people had certain educational materials and other resources that they needed. One presenter looked at me and asked, "How do you know what they need?" I was beyond humbled. There was a lot I didn't know and still don't know. I got a quick lesson on cultural humility, which is very different than cultural competence. Cultural competence says, "I'm the expert." Cultural humility says, "You're the expert." Cultural humility recognizes that every culture is unique and there are a lot of things we don't know. In fact, we don't know what we don't know. We must incorporate cultural humility into cancer care to foster equity and inclusion. We can't make our own culture the standard. We have to take steps to understand each person in their own cultural context. What we see and hear depends a good deal on where we are standing. Sometimes what we think we see can be very different from what others see. You can't help a person if you don't understand them or know what they need, what their community needs. The context in which people live must be considered. Federal reparations provide a framework to mitigate disparities, but true systemic change is a team sport. I implore you to look at your own implicit biases, recognize them, and work to dismantle them. Physicians are an important part of the team and at the heart of working towards social justice in healthcare. This is a marathon, not a sprint. Incorporate cultural humility into your work. Black people are not a monolith. The LGBTQ plus community is not a monolith. I'm Jewish, and I can tell you that Jewish people are not a monolith. And it's okay to make mistakes. We all make mistakes. The important part is to acknowledge them and then keep moving forward. And remember the butterfly effect. One small change can have a big impact on the future. And please do what's right, not what's easy. We need to speak up and speak out. Indifference and silence only perpetuate injustice. Health equity must be a priority, not an outcome. I don't understand what it's like to be a minority, and I understand that I will never understand, but I can and I will stand. I urge everyone to stand with me. Take a pledge and commit to self-reflection, to acknowledging disparities exist, to embedding a health equity lens into all of your initiatives and programs, to practice cultural humility, and to prioritize people over profits in your institutions. In the words of JFK, every accomplishment starts with the decision to try. Today, I am asking you to make the decision to try. I am asking you to stand, and I am asking you to join me and shoulder the burden of knowing, the burden of lives that depend on us. And as John Lewis said, if not us, then who? If not now, then when? Thank you.